Bismillahirrahmanirrahim. So today I'm gonna talk about approach to arrhythmias. So first we're gonna talk about the bradyarrhythmias. So let me show you how we're gonna approach to the arrhythmias, right? So if any patient is complaining of the chest pain, right? If patient is complaining of palpitations, right, or dizziness or syncope, right? So what we need to do, we have to get the ECG done, right? So once we get the ECG, we will have to check the heart rate. So if it is more than 100 beats per minute, we're going to call it as tachyarrhythmias, right? So I will talk about tachyarrhythmias with tachyarrhythmias topic. So if heart rate is less than 60 beats per minute, so we're going to call it as bradyarrhythmias, right? So the next thing is to check the PR interval, right? So we'll have to check the PR interval. If it is prolonged, that means it is more than 200 milliseconds, right? Or 5 small scales, right? Okay. If PR interval is prolonged, so we will check the next thing is to check for the whether there is fixed block, right? Whether there's a beat drop in that. So I'm gonna classify that accordingly, right? So it can be first degree, second degree, or third degree. So it can be heart block basically, right? So if PR interval is normal, right, so the next thing is to check the PP interval, right, from one P wave to another P wave. So if PP interval, it is normally less than 2 seconds, right? So if it is more than 2 seconds, right, so it is basically 6 sinus syndrome. So if it is normal, PP interval is normal, and but the heart rate is less than 60 beats per minute, so it is called as sinus bradycardia, right? So I'm going to talk about sinus bradycardia, 6 sinus syndrome, and heart blocks in these. So I'm going to discuss the pre-excitation syndromes. One is called as long Gannon-Levine syndrome, and another one is called as the Wolff-Parkinson-White syndrome, in which we're going to see the PR interval basically which gets shorter, right? So if PR interval is short, right, so there are two possibilities of that. One is called as Wolff-Parkinson-White syndrome, and another condition that is called as long Gannon-Levine syndrome, right? So I will talk about that in separate section in pre-excitation syndromes. Okay, so so let's talk about sinus bradycardia today, right? So first we have to see the classifications again. So rate will be less than 60 beats per minute, and if we check the PR interval, so it will be normal, right? And the next thing is if we check the PP interval, so that will be also be normal, right? It will be less than 2 seconds. So we have labeled this patient as sinus bradycardia. So it is a benign condition, right? So to label this as sinus bradycardia, heart rate should be less than 60 beats per minute when the patient is awake. So when the patient goes to sleep, so it should be less than 50 beats per minute. So causes include in athletes, right? So basically what happens in athletes, there is tachycardia, right? So because of tachycardia, right, so our vagus nerve gets more activated, right? So because of high vagal tone, they usually have bradycardia in the resting position, right? So because of high vagal tone, right, vagal tone, right, so and that's how they're gonna get the sinus bradycardia. So sinus bradycardia can also be seen with ischemic heart disease if the patient is taking beta blockers, right, or patient is having hypothyroidism, hypothermia, and digestion toxicity, right? So these are the causes of the sinus bradycardia, right? So if patient gets symptomatic, so we'll have to give this patient injection adenosine, atropine 1 mg, right? So we'll have to give injection atropine if patient gets symptomatic. Otherwise there is no need to treat this patient, right? So if patient is asymptomatic, right, so then we'll have to treat the underlying cause. If the patient is taking the beta blocker, so we'll have to taper off the dose of beta blockers, right? So we'll have to treat the hypothyroidism, hypothermia, and digoxin toxicity, right? So that's all about the sinus bradycardia, right? The next thing is, if we see, then let's come back again. If we see the PR interval is normal, right, and the rate is less than 60 beats per minute, and the next thing is to go for PP interval. So if it is more than 2 seconds, we're going to label this patient as sick sinus syndrome, right? So sick sinus syndrome, sinus bradycardia is called as a benign condition. It is also a benign condition, but sick sinus syndrome is a malignant bradycardia. So it is a malignant condition. So causes include the ischemia and infarction of SA node or degeneration of SA node, right? So in sick sinus syndrome, sometimes we won't find any P wave, right? So sometimes P wave is absent. So let's talk about causes in which there is no P wave, right? So there one is sick sinus syndrome, right? If we get the P wave, so we'll have to check the rate between the P wave. It is, if interval is more than 2 seconds, we're gonna label this patient as sick sinus syndrome. Or if there is absent P wave, right? And first cause is sick sinus syndrome. The second one is called as atrial fibrillation, right? And third condition in which we won't find any P wave, that is hyperkalemia, right? Hyperkalemia, right? So if patient is asymptomatic or symptomatic, we'll have to treat this patient. We'll have to put this patient on permanent pacemaker. Along with that, we'll have to anticoagulate this patient. And why to anticoagulate this patient? Because we have to we put this patient on pacemaker, right? So we have placed the pacemaker. So wires are actually a foreign body, so we have to we have a single lead pacemaker, then double and triple lead pacemaker, because wires are the foreign body, so they can cause the superior vena cava thrombosis. That's why we're going to give this anticoagulation to this patient, right? All right, so that's all about the sick sinus syndrome and sinus bradycardia, right? The next condition is heart block. So let's talk about heart blocks, right? Okay, so when conduction of impulse from atria to ventricle is impaired, right? So that's how we're going to define this heart block. So let's talk about, so we'll have the causes of heart block. We'll talk about that. So it can be congenital, right? It can be seen after post it can be seen post MI or ischemic heart disease of anterior wall, as conduction system is present in mostly present in anterior wall, right? It can be seen with Chagas disease, right? So it can be also seen with sarcoidosis, infective endocarditis, and Lyme disease, right? So I'm going to discuss the causes of that separately. So if we talk about first degree heart block, right? So when impulse from atria reaches to ventricle but it gets delayed, right? So let's talk about that. So you can see here that we can there are some this is SA node, right? So this is SA node, right? And this is AV node, right? So let me draw it here. So this is SA node, then we'll have these our internodal pathways, then we'll have this AV node, right? Then we'll have this bundle of His, then right bundle branch and left bundle branch, and left anterior first fascicle and left posterior fascicle. If there are some nodules here, if there is some infiltration here in these internodal pathways, so pulse will be conducted to AV node, right? But with delay, right? So basically problem is in internodal, between two nodes. Problem is internodal conduction defect, right? So let's talk about what are those conditions. So one is called as Ashkoff nodules, what we find in rheumatic fever, right? So problem will be in internodal pathways. So first degree heart block can also be normal, like in athletes or marathon runners, because of high vagal tone, right? Just like sinus bradycardia. So rheumatic cause like Ashkoff nodules will be there if there is deposition of iron here, so hemochromatosis and sarcoidosis, and if there is fibrosis of these pathways like endomyocardial fibroelastosis, right? So normally what happens if we if with the exercise when there's increased heart rate, so PR interval gets short, right? So normally this PR interval is variable. If you ask the patient to get to exercise or do the sit-ups, so what's gonna happen? PR interval gets short. But in the patients with the heart blocks, so PR interval will be fixed, right? So it will not be variable, right? So the patient is going to complain of exercise intolerance, fatigue, right? So if we check the ECG of this patient, so PR interval will be prolonged, right? So PR interval will be prolonged in each of QRS complex. So if we just say that this is more than 200 milliseconds, right? So it will be more than 200 milliseconds, but there won't be any drop of the beat in these patients, right? So there will be fixed block here. So right, so I have discussed about the causes of that, right? So PR interval will be prolonged, but there won't be any QRS drop beat, right? So if patient gets symptomatic, so we can give the patient injection atropine 1 mg. We can go for temporary pacemakers, right? So we usually go for transvenous pacing or transcutaneous pacing, right? So I'm going to talk about that later on, right? So then the next thing is to treat the underlying cause. So that's all for the first degree heart block, right? I think that's enough for today. So I have talked about sinus bradycardia, right, sick sinus syndrome, and first degree heart block. In the next video, I'm going to talk about the second degree heart block. We have got two types of that. One is called Mobitz type 1 and Mobitz type 2. Then I'm going to talk about the third degree heart block, right? All right, so that's all for today.